So today it's my pleasure to introduce Dr. Linnell Schneeberg. She's an assistant clinical professor in our department, and she is a licensed clinical psychologist, and she is board certified in sleep medicine, and one of the few in the country that has that designation. She also directs the behavioral sleep medicine program at the Connecticut Children's Medical Center. She is based out of our program here at Yale, which is at North Haven and Madison.
That's right.
And I also found out today she's on Twitter, so we can follow her for even more information. She's going to give an overview of a lot of brief interventions for various sleep problems. This is a taste today, so depending on our interests and needs after this, we can always welcome her back. But I'm going to turn it over to you and get started.
Thank you. Thank you for coming. I just want to start out by saying that I'm fine with keeping this informal. So if there's a question that's on my slide that you have a question about as we go, you think it's a little bit more on the brief side, just ask it as we're going. And then at the end, I always try to save time for cases and questions and whatever anybody's interested in. Great. Okay. So as we go, Lisa and I talked, and we were trying to figure out what would be the four most useful topics to cover in more of a brief fashion. And the first one that we talked about is, I think most people are familiar with cognitive behavioral therapy for insomnia, but there's another therapy called brief behavioral treatment for insomnia. And that seemed like a really good one to pick because a lot of people can deliver that in a much shorter, briefer way. And then the next one would be to, a lot of people always ask me, do you think, if I snore, do you think I might have sleep apnea? And apnea is very prevalent, so I thought it might be nice to cover a brief screening instrument for apnea. And then there are a lot of people, too, who struggle with circadian rhythm disorders, which I kind of joke should be called the teenage disorder, right? So they're falling asleep really, really late and waking up late, and they're in trouble. They're in trouble. A lot of times they end up with me because of guidance, sending them. So I thought we'd talk about that. And then lastly, there's Dr. Melissa Knauert, who some of you may know. She's in our sleep department, and she and Margaret Pisani, Dr. Pisani, are really pioneers in this area of improving sleep for hospital inpatients, because the hospital is not a very great place to sleep, and that's unfortunate. So I'm going to talk about that too. Okay, so brief behavioral treatment for insomnia. Insomnia obviously is a huge problem. It affects lots and lots of people. And in our setting, you'll see an even higher incidence of it. CBTI is the practice standard. It's the thing you're supposed to do first, before Ambien, before anything. But the problem with CBTI, as you all are aware in this room, is the dearth of practitioners that are well-trained. So CBTI uses a lot of different methods: stimulus control, sleep restriction, anxiety management, cognitive reframing, all kinds of things. So some very great people have pulled out some of the most important components that are behavioral and built that into BBTI. It's basically 4 sessions, 2 are by phone, so it's pretty easy to deliver. But even less than that, I'm going to give you the 4 rules today that you can talk to any of your patients about. Okay. And so it was developed to be brief. It was developed to be acceptable to patients, mostly because of this bottom item. There's really no stigma of a brief behavioral treatment. It's not really called psychological treatment. It doesn't have to be delivered by a psychologist and so on. It can be delivered by anyone with just a little bit of specialty training, and it works pretty quickly. So the 4 rules are as follows, and the second page of the handout has the 4 rules. We'll make more. We'll have some more. And it has on the left are the 4 rules, and on the right are the common obstacles, the things you'll hear patients actually say, the reasons they think they can't do that rule. So there's sort of a built-in a little bit of cognitive piece on that. So the 4 rules are to reduce your time in bed. I'm going to talk a little bit more about that on the next slide. But basically what you do is you calculate how many hours the person is in bed, and you're really trying to make that equal the number of hours they sleep. So lots of people who have sleep troubles will go to bed quite early hoping to fall asleep, and they'll stay in bed later hoping to catch up. They might be in bed 9 to 9, for example, 12 hours or some kind of crazy number like that. And you'll say, how long do you think you're sleeping? And they'll say 6 hours. So they're in bed twice, as much time awake as they are asleep, for example. So reducing time in bed, you do hours in bed, trying to equal it to hours of sleep plus 30 minutes, because obviously it takes you a little time to fall asleep and you might wake up in the night for a little while. The second one is a biggie, getting up at the same time every single day, no matter how well or poorly you slept. Most people have this myth that they should catch up on the weekend. You'll hear that over and over again, right? But your body is an amazing thing, and when you're sleep deprived for even a day or two, it sort of steals sleep from the lighter stages and moves it over into the deep and REM stages. So your body already is doing the work for you. If you need to catch up, it's catching up by adjusting the percentages even within the few number of hours you might be getting. So catching up is almost always counterproductive, and it's almost always something that really wreaks havoc with your circadian rhythm. So getting up at the same time every day is a great, great habit. Don't go to bed until you're sleepy. So a lot of people go in bed and just sort of sit there and hope they're going to fall asleep, and that's really not a great plan. So we love to have people wait until they're drowsy. And then lastly, that last one is stimulus control, right? Don't lie in bed unless you are asleep. Stimulus control just means using your bed as a stimulus for sleep only, not for wake, not for eating, not for working, not for being on your phone. I'm not a purist about the last one. Some people are. Some people are very strict about moving out of the bed and moving back only when you're very drowsy. But as I'll talk about later, I like it when you have two states for your bed. And you all know behaviorism, so I don't have to talk about that very much. But you can have a state where you're sitting up and relaxing and reading, and a state where you're lying down and sleeping. And to me, that fulfills the requirement of, not lying down awake in bed in the dark, hoping to sleep. Okay, and this is the slide just on sleep restriction, just to make it a little more clear. So basically you want your time in bed to be very efficient. The amount of time you're in bed versus the amount of time you're asleep to be a very high ratio, 90% or so. The minimum of time we would ever allot is 6 hours. I do see people who tell me they sleep 3 or 4. Maybe they do, but I don't ever put anyone in bed for less than 6. Okay. And then bed rise time's consistent. And then a lot of people who have insomnia, they'll say, I never take a nap even though I want one because it'll ruin my nighttime sleep. And that is not true. It's not true at all, because your melatonin is released in a large burst, in the evening for sleep, but you have a little burst of melatonin that's released in the afternoon too. So your body, in a way, expects a nap. And as long as you keep it short, between noon and 4, half an hour or less, there's no worries about it wrecking your nighttime sleep. The time that it'll wreck your nighttime sleep is if you take it in the forbidden zone, which is after about 6 p.m., and then you really push your bedtime if you do that. Or if you nap in the late morning after you've gotten up, your body's not sure if that's just more of your sleep time or whether that's a nap. So there's 2 processes that everyone always talks about in sleep, process S and process C. Process S is the sleep drive. That just means that the longer you've been awake, the more likely you are to fall asleep. That makes sense, doesn't it? And you also have, of course, hormones in your body, adenosine, that build up over the day and just make your sleep drive very, very, very high. So some people call it prior wakefulness, some people call it sleep drive, some people call it process S. But the people who are in bed from 9 p.m. to 9 a.m., they really don't have that going on for them. They really don't have that working for them. And the other process in sleep is process C, and that stands for circadian rhythm, which means, again, if you try to sleep at a time that your body is most likely going to want that, then you have a better chance of falling asleep. So if you were to match someone who's sleeping 9 to 9 but only asleep for 6 hours, I might put them in bed midnight to 6 because they're going to have a high drive to sleep between midnight and 6. I wouldn't put them in bed 9 p.m. to 3 a.m. because who wants to be banging around the house at 3 a.m., right? So I'm trying to always match what seems to fit for most people, and that would both fill the process S and process C sort of drive. Any questions about any of that? Okay. So here's the next one. People will say, if you're used to spending lots and lots of time in bed, the patients will say to you, what am I going to do with all that time, right? And that's where you come in. It's really important to talk to them about what do they like to do? What do they never have time to do that they've given up? I ask a lot of retirees, what did you used to do when you were a teenager? Did you paint? Did you have woodworking? What did you do? So they're really meant to keep their life running all the way up until the time that they get in bed. So they can do any kind of quiet, relaxing activities that they enjoy. And there's some other ideas here too, right? So they should be distracting but not overly stimulating. That's really not the time you want to be working out, within 3 hours of your bedtime. Fairly low light settings, not your computer all bright or your iPad really bright. No work, certainly, right? You don't want to be revving up your brain for your work or your academics. And the ones on the bottom there are the ones that I recommend the most. Podcasts, audiobooks. I see a lot at Yale Center for Sleep Medicine. I see a lot of patients over 65, and a lot of them have smartphones, but they don't know how to use podcasts. Podcasts are fantastic. So I'll take their phone and show them how to set it up and download a few podcasts, and they love them. You know, who doesn't love a great podcast about something that you're really interested in? So those are great.
The avoid electronics part?
Yeah, we should talk about that. I'm going to actually do a whole slide just on that because that's huge, right? Yeah. Okay. Okay, and then the outcomes are really, that's a small n, 82, but still, they're nice numbers. You know, people got a very nice outcome from BBTI. They really are the 4 most important rules, behavioral rules, that we would teach anyone that we were working on for insomnia. So, significantly improved self-reportive sleep, as defined by the Pittsburgh Sleep Quality Index. You could look that up, but it's a nice sleep quality index. Or an increase in 10% in their sleep on their sleep diaries. So those are nice. And they're less likely to carry a formal diagnosis of insomnia after BBTI. Okay, so that's BBTI. I'll pause just a minute. Are there questions just about that? This is the first of the 4 things we'll talk about.
Can I ask a question about the sleep journals?
Yeah.
So just in terms of having people be aware, so I know that one thing I've talked to patients before is that for them, checking the clock and realizing how much they're not sleeping really feeds into the anxiety of not sleeping.
I know right where you're going.
So I guess
Yes.
I'm wondering, with keeping a sleep journal and being
Yeah.
aware of
Yes.
whether they're not falling asleep or falling asleep, how do you
Super great question. So I have sleep diaries later in my talk when we talk about circadian rhythm, so I'll show you the one that I like. But the one I love the most, I brought a couple of people who were filled out some. So they're essentially just, this is 2 weeks on one page. There's just a box, 24 boxes for every hour of the day and night across the horizontal, right? And all you do is put a down arrow when you get in bed, an up arrow when you get out, and color in black the squares when you think you were sleeping, and leave them white when you think you were awake. And what I say to them always is, do it in the morning at the breakfast table from your memory. Don't be looking in the night at all. And what I do when I see them the first time is I whip out one of these logs and I say, what did you do last night? And I'll show them that I'm doing it really from their recall of last night, and they all can recall. Yeah, I woke up around 3, I heard the dog bark, I heard the clock chime 4. They pretty much know, but you're so right. People with insomnia are already the ones that fill out like both sides of a piece of paper in tiny writing around the corner, right? So I'm asking them really to just do it from recall. And I usually say put it by your breakfast table or, the back of your front door or somewhere that you're going to see it. Yeah.
So I didn't see mention of stimulating medications or caffeine or things like that.
Yeah.
I assume that that's something.
They're in the workbook for BBTI. They do cover basic sleep hygiene. So they do cover no caffeine afternoon, only 8 ounces of caffeine, don't smoke at night. So they do cover that. Yes, there is an actual workbook that's really great because it serves as both a reference to them and sort of a questionnaire. And so the formal BBTI has a workbook that the patient has, and you work through 4 sessions.
Is that on your materials?
Yes, I do. It is, yeah. And then I also have, if anybody wants it, I have the actual cover sheet of the best article. This is really the best article covering BBTI. Yep. Anything else on BBTI?
Just following it, the not smoking before you go to sleep or whatever. If somebody's a really heavy smoker and they think they would wake up because of nicotine cravings, is there truth to that? Or
Yeah. There is truth to that.
So would some of those people actually benefit from having a nightcap smoke so that they don't get
They might,
awake in the
yeah,
middle of
they
the night?
might. What do you tell your patients smoking pro? What do you tell them?
I think that's when we probably would recommend nicotine replacement, right?
Yeah. Yeah. It's really an ingrained behavior, isn't it? It's such like a grooved behavior. Yeah. And your body has so many clocks, not just your, neural clock, your every kind of clock. Yeah. Okay, sure. Alcohol, yeah. So we say, 1 to 2 drinks, depending on if you're male or female, and by 3 hours before bedtime would be ideal. But of course, many people are self-medicating with alcohol. And we tell them that it makes your sleep lighter and more fragmented. It does put you to sleep, but it'll ruin your quality. And you wake up a lot. In the second half of the night, once your deep sleep is over, you'll start waking up a lot. Yeah. Does that answer your question? Yeah, okay. Anything else on BBTI? Yeah.
I would just comment about the smokers. Some of the smokers don't really understand that nicotine is a stimulant.
I know.
Right.
I say a lot, EENS, caffeine, nicotine, right. I know. Amphetamine. Right. It's so important. It's amazing some of the basic knowledge you think people have, and they just don't. They really don't. Yeah, that's a good point. Anything else on BBTI? Okay. All right. So let's talk about apnea. This is a nice, quick way to screen. It's called the stop bang, and that's the first letter of all these words, right? So do they snore? Can they be heard through a closed door? Do they feel tired and sleepy in the daytime? This is a big one. Has anyone observed, an apnea? Has anyone witnessed an apnea? Right. So I always joke that we would not have anybody in our sleep center unless there were wives. Right, because they're all dragging them in there, right? They're dragging their husbands in there most of the time. Blood pressure. So are you being treated? And again, how you ask that question is so important. I used to ask, do you have high blood pressure? People would say no. I'd say, but you're on. And they'd say, oh yeah, but it's treated, so I don't have it, So now I say, do you have blood pressure that you're being treated for? High blood pressure that you're being treated for. Body mass index of more than 35, age over 50, neck circumference of 17 inches, 40 centimeters, or a gender male. So if you answer yes to 3 or more, if you find a yes answer to 3 or more, then you would want to refer them either to their primary care to run through those symptoms or to a sleep clinic, sleep study. And sleep studies now, again, I don't know how many of you work in sleep, but sleep studies now are often a little briefcase that you take home. So a lot of people have anxiety about sleeping in a sleep center, and I always tell them, you can just, see a doc, get the order for the sleep study, come pick it up, we show you how to put it on, you take it home and wear it. Anybody have questions about home sleep tests or sleep studies in general?
I'm just wondering what your experience has been with folks wearing Fitbits
Yeah.
and things like that.
That is such a great question. Yeah, so almost everybody has one now, and usually all they do is raise anxiety. They're not particularly accurate. If someone thinks that they're sleeping well when they're wearing them, then I'll reinforce that and say, oh, absolutely, that's great, right? Yeah. But if someone says, oh, look how much I'm awake, right, I'll say, it's just a movement monitor, right? That's all it is, right? Yeah. And there are a lot of studies out there where they've taken people's Fitbit data and matched it to the gold standard, which is a nocturnal polysomnography, right? And they're not very accurate. The last thing I'll say about home sleep tests is that they severely underestimate the prevalence of apnea for thinner women. So what I tell my patients is your insurance company is going to want us to do a home sleep test. That's like a golf cart, okay? And the sleep lab is like, your favorite fabulous car, a Lexus, right? So we're gonna have to do the low-end test because your insurance company is gonna make us, but if it's negative and you're quite convinced, or your wife or spouse is quite convinced that you have apnea, please then request to go ahead and move to an in-lab study. So we don't wanna miss it, right? It increases your risk of heart attack, stroke, high blood pressure. There's a lot of adverse events if we miss it. Okay, and the last thing I'll say about apnea is that if you have a loved one in your life who you think might have apnea and they won't go for a test, I always tell people, tell your spouse that's what you want for Valentine's Day, or your anniversary, or just a way to kind of get them on into the lab, because if you love this person, it's really not good to have untreated apnea, is it? Undiagnosed and untreated apnea. If they're a sports fan, I tell them about Reggie White, who died in his 40s. He's a football player, and he did not pay attention to his apnea, and that was not a good outcome.
If you have a
Yeah.
positive outcome on the home study, do they then do the full study?
Nope, they go ahead and prescribe the
So
CPAP.
there are no false positives?
Not really. Yeah. It's an oximeter, right? It's really looking at desaturations. It's looking at pauses. You have an effort belt. Yeah.
But negatives, like you're talking about the thin women.
Negatives, I worry much more about negatives. Yeah.
On the screening, realizing it's only a screening, but a whole lot of people are going to be male and over 50, and some of them may have been chronic snorers. I mean, is there a lot of do you really want to refer everybody who screens positive on snoring 50 and male?
Snoring with a pause, yes.
No, I don't mean just snoring. Loud
Snoring, loud snoring, yes. Yes, loud snoring. Soft snoring, no. Soft snoring with no pauses, no. But my own feeling is you have insurance for a reason. Why would you not rule that out? It's a simple test to rule out. And it's one of the diagnoses in medicine where we have a silver bullet, right? If you have apnea and we find it and treat it, you're going to feel amazing, right? I have so many people who say, I have a cabin in Vermont I never went to, now I'm driving there again. I have a workshop that was dusty, now I'm going out there again. My family tells me I'm irritable all the time. There's so much upside to treating apnea. Metabolism improves, weight comes off, irritability, mood. I mean, there are so many positive outcomes for treating apnea that I always feel like, why not err on the side of at least looking for it? Yeah. And if I can move to kids for 1 minute, I do love treating sleep disorders in kids. And so many kids are being labeled ADHD and being put on significant medications. And the problem with that, in my mind, is they might have sleep apnea, right? They might have big tonsils. And if you have big tonsils and you don't sleep well as a child, you look hyper. You don't look tired, right? You ever taken your kid to a Super Bowl party and kept them up till midnight? They are wired. Kids who are sleep deprived are really, really hyperactive. So I really recommend, I speak at pediatrician offices around the state, and I always say to them, don't medicate a child until you've ruled out sleep apnea, because that's an easy fix, isn't it? Tonsillectomy and you're good to go sometimes. Anything else on apnea?
So just go back to kids. Do insurance companies cover apnea
Yes.
for kids as well?
Yes.
Okay.
Insurance companies love to treat apnea because it saves them so much money. Think of the adverse outcomes, a CPAP machine or a stroke. That's a big savings. Yeah. Okay, great. All right, so then the third one is circadian rhythm disorders. We'll talk about that. So there's the diagnosis. It's not very hard to figure out what a circadian rhythm diagnosis is, right? So you have persistent symptoms of insomnia or a very sleepy or sleepiness with occupational social impairment. There's a lot of kinds of circadian rhythm disorder, but a lot of them are rare, non-24 hour, and there's a lot of kinds, but I'm going to talk about the two kinds that are the most common. Delayed sleep phase, should be called the teenage sleep disorder, and advanced sleep phase, which, happens a lot to people, in their latter decades. Oops, sorry. So really your best friend is a log, and that is the log that I was talking about a minute ago. It's so easy to use. If you look at the bottom, there's a key. So this particular person has a down arrow. Can you tell what time? 9:30, yeah. Can you tell what time they fall asleep? Yeah, sleep a couple hours. And they have that dreaded middle of the night awakening for an hour and a half. People hate that. And then they went back to sleep at 2:30 and slept till 7. Got out of bed at 7:30. So how many hours were they in bed? Can you see it? 10. And how many hours were they asleep? 6.5. That's not a great ratio, right? And then they took a nap as well. So for circadian rhythm, this would be an example on the left of how someone might fill it out. There, on the left one, there's a nap from 6 to 7:30. Somebody maybe fell asleep in front of the TV. They got in bed at 10, took melatonin, fell asleep at midnight, was awake from 3 to 4, woke up at 7, got up at 7:30, had coffee. So M is melatonin or medicine, and C is coffee. You can do that if you wish. And then the next one, right, medicines at the same time, got in bed, but they slept really, really long. You know, that's what a teenager's sleep might look like, for example, on a Saturday. On the right, all I'm trying to show you is that the other reason I chose this topic for this group is that you might be working with shift workers, right? So whenever we go to sleep conferences, what they tell us over and over again, the circadian experts, is make sure that somehow your bars, and now you can see what bars are, overlap. So up top, where above the dash line, they don't overlap at all, right? That is so confusing to your body. Down below, they do. So you really have to work with the person. It's hard to overlap the bars. It's really hard. That's not easy. I don't want to soft sell that. But, you know, what kind of childcare needs do they have? But sometimes you can have someone who might sleep from 6 a.m. to 11 a.m., for example, and then to add a nap. You with me on the overlapping of the bars? Yeah. So you can just have someone do a true baseline for you for 2 weeks or longer, depending on how often their shifts change, and then really look closely at whether you could make their bars overlap. Yeah.
Are there apps that you know of that can record this in an electronic manner?
Yeah, there definitely are. Believe it or not, though, a lot of times I transcribe the app back onto paper because it's just so easy to see, right? Especially it's so visual to see all your bedtimes, the arrows moving around and the rise times moving around. Some of the apps are better than others to show you the bars, you know, the sleep periods. Yeah. And one reason this is so important, just besides just feeling good, is that sleep shift workers have higher rates of cancer. So you're really trying to work with their sleep and make it good and make it overlap. Okay. Questions about this particular?
And the overlapping is from the days they work and the days they don't work.
Yes, exactly. And usually you can find a little bit of a way to overlap, especially if you add a nap somewhere in the day for them, day/night, the 24-hour day. Okay. And then these are pretty basic, but these are the recommendations that I would be running through with people, right? So consistent sleep schedules, avoid variations of more than 2 hours. So for adolescents, we call that school plus 2. So if you have a teenager who sleeps 10 p.m. to 6 a.m. and then sleeps midnight to 8 a.m., that would be perfect. So whatever their school rise time is, plus 2 hours is their Saturday, holiday, Sunday rise time. School plus 2. That is hard. That is very hard. Anybody have teenagers in this room? Yeah, it's really, really hard. So what I...
Teenager up at 8 o'clock on a weekend?
I know, it sounds crazy.
Explosion.
Exactly. So I'm saying that knowing that they're going to slide it, but they're not going to slide it, I hope, till 1, which is when they are sliding it, right? And the other thing I say to parents is, you should not be the one getting them up. Their girlfriend should come over. Right?
Girlfriend's going to be asleep too.
Probably. Probably. I poke around for maybe they have a... What's that?
Hopefully not together.
Exactly.
It's a permissive house. Not my house, no.
But if their girlfriend comes over at even 10 o'clock with an egg sandwich, you know, that's still better than 1 or 2, right?
Why can't the boy bring an egg sandwich?
Of course they can.
My daughter's just
Of course
as
they
much
can.
a sleep champ as the boys.
Yeah, they're really tricky. They're really tricky. Maybe they have a sports event. I'm just looking for any little purchase, right? Send the dog in.
Is it, I mean, don't want to over pathologize.
Right.
All kinds of kids have crazy sleep schedules. Many of them
Great
don't,
point. You're so right.
Don't suffer insomnia.
It's
They're
only
fine
10
with what they do.
It's only 10% that have a real problem.
Yeah.
Yeah. So all of us in this room did what we're talking about, right, when we were teenagers. And 10%, though, have a real tough time. They can't, you know, they've slept in twice on Saturday and Sunday night they can't fall asleep, and Monday morning they can't get up, and they miss Monday. You know, by the time someone arrives to me, if they say, I miss 1 or 2 days of work every week, I'll say, I bet it's Monday. And they'll say, yeah, it is. So that's a very good point. It's really only if there's a disruption, if it's really causing a problem in their life. Yeah, with school. It's always with school. And there are schools in Connecticut that run noon to 4 for some of the kids who really can't manage this. But again, that's hard. It's a hard, you're leaving your friends behind to go to those schools. I'll write letters for the students that I see to try to have first period be a study hall. I'll work with them in a million ways. But getting up at 6 and getting up at 1 in the afternoon is a really bad plan. And a lot of times what I'm talking to them about is if we can just work this out and get you through high school and college, I'll write you any kind of letter you want, right? This kid has to take classes only afternoon, only those sections that are afternoon. So anyway, it's tricky, very tricky. Those are the hardest patients, the teenagers, I think, of the sleep patients. Okay, light exposure. So, well, the second one, the bedtime is 16 hours after rise time. Your body expects to sleep about 8 hours and be awake 16. So again, I say to teenagers I work with, if you're getting up at 2 p.m. and trying to go to bed at 10 p.m., your body doesn't understand that. Light exposure, so in the morning, it's nice to get some kind of sunlight exposure or opening the blinds or something happening right where they're waking up with the light. Melatonin, napping at odd times of day, we talked about that one already, and napping for too long. More than an hour, really, and at the wrong time of day.
Realizing it's out of your scope of practice, but melatonin, your recommendation about dosing, time of dosing?
Yeah, that is the second most common question I get asked. So melatonin can be used as a chronobiotic or a hypnotic. And as a chronobiotic, so you sort of take it closer to your bedtime if you want to use it as a hypnotic at a larger dose, a chronobiotic more around dinner time if you're trying to sort of mimic the body's rhythm. It doesn't work for lots of people. It works for some. I have patients who swear by it, but I have other ones who say that didn't do a thing for me. And I'd rather do behavior change than melatonin any day of the week.
We're seeing, we're using it a lot more.
Yeah.
You often see it just written at the standard, hospital HS, which is 9 o'clock, nobody's real HS. So it probably works out okay because they don't really go to bed that early. But I thought really as a hypnotic, the thought is like 2 hours before planned bedtime.
Somewhere around there, yeah. And what are you dosing? What are you prescribing? 3-ish?
I think the hospital has 3 and 6.
Yeah.
I've seen 5 in nursing homes, but the
Yeah.
hospital has 3 and 6.
Right, and my own understanding, you all probably know more than I do about this, we do 0.5 if it's more the chronobiotic.
Oh, okay.
Yeah.
Assume
At
some
dinner.
endogenous already, and you're just beefing it up.
Yeah, exactly.
Can I ask about the naps?
course.
And I don't know if this is lore, but there's these short, as alluded to on this, short power naps are
Yeah.
supposed to be more rejuvenating than like an hour-long nap.
Yeah, and it's personal. I mean, I think it is personal, but there's something called sleep inertia, and you've all had that when you've napped too long and you feel so groggy, you can't even remember like who you are practically, And I do love a short nap. I think most people do really well with a short nap. So, does that answer your question? Yeah. Just you have to sort of test it out. There's a funny story about Edison that he napped. When he got sleepy, he hung a spoon on his nose, and when he fell down and the spoon fell off, that was the end of his nap. That's a pretty short nap.
That's short.
So anyway, okay. And then here we go with the electronics, right? I promised to talk about electronics. So, of course, electronics have blue light. Of course, they're stimulating. Of course, I tell my teenagers that I work with that, it's the world in the palm of your hand, right? You can talk to anybody you ever met. You can watch any movie ever made. It's pretty stimulating. And it's also pretty Pavlovian. When you hear the ding, you got to check, right? It's pretty hard. So I love it if they're away. Clock watching, you hit upon that one. It's a great one. Blue light blocking. Every teenager that I work with now knows exactly how to use night shift on their phone. Many adults I work with, it's on their phone, but they've never seen it. So we look at their phone and settings, display and brightness, right, night shift, and we turn it on. I'm always surprised to find it there on their phone, but it's great and it works really well. And it turns your phone such a nice amber color, and it's kind of like a cue for bedtime, right? So iPhones are set up from 10 p.m. to 7 a.m. to have that as their automatic setting. And I do find it, even for myself, I find it as a cue. It's a cue to head for bed. The other ones there, F.Lux is for a computer. right? If you have a computer and you want to block the blue light, and then night filter is the Android. Every phone has a version of it. Questions about electronics? Okay.
No, I'm wondering if you could advise people what you think about TV.
Yeah, I do not like it. I do not like it. And I see kids, Connecticut children's, they're 1, 2 years old with TVs. Every room has a TV. I always tell parents, take it out now. Take it out now. It only gets worse. And it's a gaming system. It's a TV. It's, you're sort of remote controlling, checking through everything. So I love it if it's gone.
Thing is, you think you're solving something by no TVs in the bedrooms, but everybody's watching Netflix on their laptop.
That's right.
Right, TVs are gathering dust in bedrooms nowadays,
Yeah.
mostly. Yeah.
But there's so many people say I fall asleep to the TV.
I
is
know.
the truth for some people because they're
Totally.
conditioned and the blue light isn't too much of an interference?
Yeah,
or-
yeah. There's something called sleep onset association, right? And you've fallen asleep with the TV on your whole life, and you would have a terrible time falling asleep with it off, right?
One of the issues that many of us deal with in inpatient settings is you can't control these environment-related.
We're going to get there. That's the next one. That's a great, great question. Yeah.
I'm also curious about how helpful you find the blue light blocking, because at least for me, I feel like I'm able to look at my
Overcome
phone.
that.
And then with the blue light filter, I feel like I will fall asleep looking at my phone sometimes.
Because it's working.
Is it because it's working, or is it because?
Here's the thing. We all have sleep onset associations.
That's true.
What'd you say?
You're sleep deprived.
Yeah, totally. So I was going to say, it's really so personal again, isn't it? There are people who don't have insomnia at all. Who cares? You know what I mean? They can do what they want. And then some people, like I use my phone at night as a Kindle with the blue light blocked, and I am looking at the screen reading. So I think it's a continuum like everything else. Does that make sense to you? Yeah. Okay. Yeah, of course. Hi. Hi.
I'm wondering if you could just share what your thoughts are on Netflix, because I know when we worked,
Yes.
so I worked with Linnell, and
Yeah.
My understanding is that you're for the use of
I am.
Netflix on a phone with the blue light off, because it's not like a TV with commercials, and
Yes.
you're not really engaging in it. It's just sort of streaming. And
Yes.
It could be used effectively as stimulus control. So I just wanted
Yes.
to make that.
Yeah,
that
I would love to
so
talk.
many of our patients who we did try to encourage them to read.
We
That's number
did.
one, or do a podcast, but some, really, especially with excessive sleep-related worry,
Yes.
we did
We
have
did
them
do
watch
that.
Netflix. So
That's
I
a
just-
great.
yeah.
That's a great point. So what Corey's talking about is that there are a lot of people who are very used to having their phone in bed, and so I encourage them to use their phone as only a book or a video player with the blue light blocked. And many of us in this room probably fall asleep watching some show or something and getting drowsy and then putting it down. So again, I'm not a purist. I'm a pragmatist. If it works and a teenager will do that instead of a different behavior that's worse, right? So it is a hierarchy in my mind. I do love a book and a book light. That's my favorite. But the second, and a DVD player, we would talk about that too, right? Remember the old DVD players? Probably have one somewhere, right? And it just, the top lifts up and you put a DVD player in it. It's not connected to anything and it plays a movie. So if I treat an adolescent who doesn't like to read, I'll often ask the parent to go dig out the DVD player and have them watch a movie on just the DVD player. There's, again, no notifications, no social media, there's nothing on there. And then I do agree with what Corey had mentioned. If someone will do fine with Netflix and that will be enough of a distraction to quiet their mind and put them to sleep, I'm okay with that. I'm okay with what works. Yeah.
Can you block the blue light on a DVD player?
The little one, they're so old. I don't know. Does anybody have one that they can block a blue light on? You could wear glasses. There's screens.
I just have these because they're my progressives.
I just want to look cool.
But there are glasses that you can purchase that block the blue light, because she uses it to watch TV.
There are some, and we will and suggest shift workers wear those home in the car, right, when they're driving home. And there are little screens you can purchase. You've all seen those that go over your computers. Yeah.
I realize that you're pragmatic. What works is great, but it seems like doing the Netflix or whatever, or even potentially the podcasts, maybe flies. Well, you're sitting up watching it, or you're lying down. If you're lying down watching TV, doesn't that get in the way of stimulus control?
Right.
And
It's tricky.
things like that?
I do like the two states where you're sitting up until you're really drowsy, and then putting it down and laying down to sleep. So your horizontal pose with your head on the pillow is your sleep pose. Does that make sense? Yeah. And so many people just have so much on their mind that if they get in bed and just lie there, you know, I think I have this on a later slide, but if you put 10 good sleepers in a lab and tell them the first one to fall asleep will get 10 grand, none of them can sleep, right? So there's just so much, and I call it the download, right? So you get in bed and everything's quiet and dark, and then you do the download of everything that's not good. So I'm really trying to occupy them. I'm really trying to give their brain some junk food in a way, right? Until drowsiness sneaks around and grabs them.
So speaking of which, when you're watching the Netflix or something, would you recommend them watching, in the chair nearby the bed, and then get into bed when they get sleepy, or like?
Yeah, if they're not very sleepy at all, yes, don't even get into bed. But if they're feeling pretty drowsy, and sometimes when they get in bed, there's the dread of the bed thing where it's conditioned and they immediately get anxious, so I might have them watch a little more in the bed. But there's so much of that with people who struggled with insomnia for years, right? They fall asleep great in the guest room, they fall asleep great in the sofa. They come to the lab and fall asleep and they're so mad. They sleep 8 hours, like perfect 8 hours, and they're so mad. One of them even said, well, you must pipe something in there. But I always say to them, that's great news. Your body can do this. You just can't do it at home. We just have to fix home, right? So you can, yeah. Yeah.
Just in regards, we've been using weighted blankets
Yeah.
in our inpatient service, and I wondered if you had any experience with the use of any weighted modalities.
I do. Are they kids? Are they adults?
Both.
Yeah. So it's very popular for the spectrum kids, right, to have a weighted blanket. My own rule of thumb if it's portable, because it becomes a sleep onset association, and then when you don't have it, what happens? Right. So a lot of young parents now are using sound machines in infant rooms. I understand why they're doing it, but that's a sleep onset association, right? It'll become conditioned, and you better be able to take it to Nana's house, and you know. So I'm fine with the weighted blanket. I see a lot of kids on the spectrum at Connecticut Children's, and they get hot. So now we're recommending either the weighted blanket or a snug bug. Have you seen those? Those are great. So those are stretchy Lycra. Does everybody know what a snug bug is? It's like a giant Lycra sock that pulls over the entire mattress, and then you get in it, like a Ted sock, sort of, right? And then it's a lot of compression. It's really comforting, but it's cool. Yeah. So having both of those is great. And the other thing I care about with kids is if you can't put your own weighted blanket on, right, that's a problem, because then everybody wakes up 2 to 6 times a night, everybody, and they're usually short if you're a good sleeper, they're long if you're not, and then you got to signal to somebody come fix your blanket. Right. Any other questions about weighted blankets? That's a great question. Okay.
The portability is interesting because my daughter is in college.
Yeah.
She uses a fan. And then there's always an issue to ask, like if the team has to travel, will the roommate be okay with a fan going all night? You know? But she takes a little fan.
I know. I have a thing I call the summer camp rule, where if you can take it to summer camp, it's okay with me. But that limits the scope, right? You can't take starlight projectors and aromatherapy misters and, right? You can take a book and a book light. You could get a weighted blanket to camp, right? You could. But yeah.
Snug bugs or weighted blankets help if somebody has restless leg? And that's why they're waking up?
Depends on the individual.
Yeah, I'd rather treat it. But you mean if a med doesn't?
Well, I mean, I don't really want to put kids on.
No, but I'm checking their iron, right?
Yeah. But if they have normal iron and
yeah,
it's not that.
You may see more than I do. I see them more having a problem falling than staying. Do you see them having trouble staying asleep with restless legs? Yeah. They might like that pressure, yeah. That would be a great thing to try. There are things that you know, like the compression, where it squeezes and then lets go and squeezes. Some people are using those. Some people are using a pad in the bottom of the bed that just vibrates. There's just something about having some kind of sensation. So that's a good point with the snug bug. Yeah. Anybody have experience with that? Restless legs and any of that? It's interesting. What'd you say?
Wonder about neuropathy too with the vibration pad.
Right. It's interesting. Okay. Oh, whoops. I didn't talk about the very last thing. So you can also work on the environment, right, with blackout curtains, which should not be closed for teenagers. White noise, noise-canceling headphones, earplugs, eye masks, temperature control. Okay. And then I just use the calf mnemonic to remember the things that wake you up. So the things that help wake you up at the right time are caffeine, activity, light, and food. And again, for teenagers, what's that? Oh, bless you. So for teenagers, don't usually like to eat breakfast. So maybe they can have a handful of nuts. Maybe they can have a protein shake. Maybe they can have granola bar, something. I always tell them, you know, drink chocolate milk, like anything to come down the hatch and turn on the stomach clock, right? Your stomach has a clock and it realizes, oh, something's happening here. This must be breakfast. This must be morning. So anything at all. Questions about calf? This is a biggie. It entrains your circadian rhythm. It's just as important as your bedtime routine. So for a teenager, that might be the blinds open, going outside to have your egg sandwich, walking the dog, walking to the bus. If you get to school early on the bus, sitting outside on the little low wall that's outside of every school, you're just hanging out there for a while until you have to go in the building, sitting near a window in your first period class, anything with light. I always tell them light is a free and very powerful stimulant. You know, it's full spectrum, coming in the eyes, talking straight to the suprachiasmatic nucleus, the clock. Okay. And then improving sleep for your hospital inpatients. So this is the last piece of the talk. All right. So there are lots of things that can happen to our inpatients. And basically, the kinds of things that you would think happen are the things that happen, right? It's more difficult to fall asleep. It's harder to move through the sleep stages because you have these interruptions. You have a lot more arousals. I'm going to show you a slide of the number of arousals. You won't believe the number. Decreased REM and decreased deep restorative sleep. All right. And when people have better sleep, they have a lower incidence of delirium. And delirium leads to lots of outcomes that we don't want. Okay. So this is just a decibel gauge. So there's sort of, you know, what everything is, right? And just remember that the number that we're looking for is 35 to 45-ish, you know, that 40 number. Just keep that 40 number in mind as I go to the next slide. And this is hospital decibel levels. And they don't even change much. They're high and they don't even change much, do they? It's pretty astounding. These are the average number of entrances into a hospital room. And Melissa, Dr. Knauert in the Yale Sleep Center, she just set up a camera and she just counted feet, right? Coming and going. And it's a lot. And it doesn't, doesn't change much. So the idea is a nocturnal nap time concept. It's one that you may already be very familiar with. But the idea is that you would set aside 4 hours to try to minimize interruptions. Maybe you would never do baths at that time. Maybe you would never, you know, polish the floor. That happens, right? Maybe you wouldn't do any of those things if you could help it between 12 and 4. You would provide, as a good behaviorist would, a signal to sleep, darkening the hallways. I worked at Gaylord for years, and they would darken the hallways, they would close the curtains, and, you know, there was a signal for sleep, and it kind of hushes everybody down a little bit on the floor too, right? some monitoring, some visitors, and the nurse is the gatekeeper. The nurse is the gatekeeper, but you need everybody on board, right? You need the people who take blood, you need the janitorial staff, you need everybody on board with that. So any questions about the nocturnal nap before I move on?
How about bedtime in general? I mean, HS is 9 o'clock, and that's not the real world for most anybody.
No, it isn't.
And you're maybe being a bad patient if you want to be up and doing something at 11 o'clock, like walk around the unit.
Right. I am going to talk about having things, having your hospital bed used in the 2 states, up and down. So let me jump onto that. So you could, again, you're trying not to have them lying around in bed in the dark. You really want them doing something until they're actually drowsy. And that's the cash price study I talked about already. If you try to pay good sleepers to fall asleep quickly, they can't. And so you could have patients, you could help them have either a book or a tablet for reading or watching videos within arm's reach with the blue light blocked. That's pretty accessible to people. And that can help you kind of, again, that becomes your bridge into sleep, right? You do this thing that distracts you. If you're in the hospital, you already have a lot on your mind, and it just distracts you from that a little bit until drowsiness can sneak around and grab you. And you could have state A and state B in a hospital bed, right? You could have your bed elevated, head of your bed elevated until you're ready to go to sleep, and then lower it to cue the sleepy time. And I think that could be helpful. Is that what you're thinking? What are you thinking? They're sort of
I'm thinking
expected to go to
it'd be nice to change the culture of the hospital to say bedtime is something later.
Yeah, because you're right. Does anybody in this, well, some people in
Because
this
if they
room
do
might go to bed at 9.
Who's sleeping until 6? They're not. You can't.
Nobody. And then you're awake at those horrible wee hours.
Right.
No one wants to be awake at 3 a.m. Right. That is a
Unless
very...
they're all your nurse. No, I mean, people.
It's so
I think
true.
hypnotics are used because somebody's up at 2 a.m. because they went to bed at 9.
I love what you're saying. I agree. And that's a cultural change, isn't it? And it's taken Dr. Knauert, she's really had to work her way through every department and get people on board with this. So she's in the ICU, which is kind of worst case, right? Yeah. I love that idea. That'd be worth investigating. Yeah, it is too early for almost anybody. Yep. Okay, and then again, even for hospital inpatients, you could still use some good practices, right? So they could have a worry time notebook, right, where they're writing about things that they're concerned about at a time of day different than bedtime. It's a place to kind of put everything, you know, what am I going to do about this? What am I going to do about discharge? What am I going to do? You know, you sort of have a notebook where you keep track of what you're going to do and things you're concerned about. And then you literally put it away before bedtime. And then you could have a notepad for anything that your brain sort of pops up and gives you in the middle of the night. Because our brains do that, right? You'll think, oh, I know where that thing I lost is. And, oh, I need to call the doctor for my mom. And, you know, all those things, those do pop up. So I love a worry notebook plus a notepad. Caffeine, of course. And then naps. We've sort of hit naps pretty hard already. And sleep rituals. You can still have a sleep ritual, even in the hospital. And you might talk to your patients about what they do at home, what they like. Do they have a certain tea that they like? Do they have a certain magazine that they save for bedtime to read? Things on their bedside table they could bring in. You know, again, I'm a sleep behaviorist, so what's going on at home that's working well? Could that be brought into the hospital setting? And so on. Okay, great. And then we've already talked about time givers or Zeitgeibers, the caffeine, activity, light, and food, minimizing exposure and activity during the day and so on, and then minimizing daytime napping. So Gaylord, for example, they're great at that, right? Everybody gets up, everybody gets dressed, everybody has therapies from 9 to 3. So they have a real day that's happening, a real night that's happening. Okay, and then this is just my own, what I share with a lot of patients on sleep meds. So, for instance, someone will come to the sleep lab and they all have to see a sleep physician before they see me, and they'll say, I can't sleep, doc, can you give me a medicine? And maybe it's a month to get in to see me or something, and the doctor feels uncomfortable not prescribing anything. So a rescue protocol can be a really nice option for them. You would give someone 2 pills a week until they would get in to see the sleep therapist. So what that means is if you have the 2 pills a week comes from, if you have 2 poor nights of sleep in a row, on the 3rd night you might take that pill. It's a really great protocol because if your Monday is terrible, Tuesday, you have prior wakefulness, right? High sleep drive, process S, and you might sleep better. And if you don't, then on Wednesday, there's your little rescue net. But you would never use it more than twice a week. Tolerance is not a problem, dependence. So the docs that I work with, we use the smallest hammer, right? The smallest dose of the kind of lightest medicine, maybe twice a week. Once somebody has had cognitive behavioral therapy for insomnia and they're better, then I somewhat flip the way I use a rescue protocol, and I ask them to use it only twice a week, but maybe on whatever night they're really worried about their sleep. So they're going to give a talk the next day, maybe, and they know they don't have adverse effects. Maybe they want to be sure they sleep that night. They could take it on a Tuesday or, whatever. They could sort of look ahead to the week and see, when do I really want to have a good night, and they'd save it for that. Do you have questions on sleep meds? This is a good time for that. Good people in the room too for that.
I know a lot of our patients have pain.
Yeah.
Some of them have acute pain, some of them have chronic pain. I'm
Yeah.
wondering about your suggestions for meds for those folks.
Right.
And also how you navigate it on the behavioral side.
Right. That's such a hard one. Sleep and pain, right? That's as bad as it gets. It's really hard. So yeah, I'm trying to make sure their pain is managed. I don't really work with inpatients at present. Anybody in the room here that does that kind of work with pain and sleep with inpatients? I mean, obviously you're trying to keep the threshold down, right? So you're managing it through the day. Anybody else have thoughts
I'm just
on
wondering
that?
who might speak,
Yeah.
no slip intended, to meds that are, least harmful to sleep architecture.
Right.
If you do have to use stuff, or including
Yeah.
pain relievers.
Yeah. We tend to pick the little, the Ambiens, those kinds of things, as a starter.
Questions around analgesics that are
Mhm.
Well,
sleep disruptive.
everything. I mean,
Yeah.
benzos get turned to a lot. I don't think they're very good for sleep architecture.
Yeah, I mean, outside of,
We use a lot of trazodone. Is that innocent or not?
yeah, it's used a lot. And, without patients, sometimes you can get away with a Tylenol PM or, a PM medication. Sometimes you can, but no, I know. No, I don't love it. I don't love it. It's a great question and a hard question. Yeah. Okay. That is it for the inpatients.